Welcome to the re-recording of the Iowa Healthcare Collaborative Falls Community of Practice webinar. I want to start off by thanking everyone for joining us today. As a reminder, our Community of Practice is an interactive resource sharing and skill building network. This next webinar will be focusing on falls assessment, and as part of our COP, we are pleased to welcome Barb Marlin, Patient Safety and Risk Management Director at Fort Madison Community Hospital. Barb is going to be joining us to share her experience with Fort Madison Community Hospital and their processes for falls assessment, both for inpatient and outpatient. So thank you again for joining us, and I will turn it over to Barb to tell us a little bit more about herself and to begin explore the experiences that they've had at Fort Madison.
Well, thank you. I want to welcome everybody and appreciate your time. I have been a nurse for 30 years now, and I have worked acute care, pretty much every department except surgery, and supervisor, and then I also have worked in a clinic and home health department, which is really has a struggle with falls in the homes. And so I am here today to share what Fort Madison Community Hospital has been doing to try to make our hospital a safer environment for our patients, our staff, and our employees. And my focus is to kind of talk about assessing for falls. So we're going to talk about, we have a fall team, and we meet on a monthly basis. And initially when I began this position, our fall team was just, I felt, in a rut. Just looking at inpatient falls and identifying if they were preventable, unpreventable, or not applicable. And I just thought our fall team could be more robust and be more active in doing more things, so we began to branch out as we were working on developing and updating our policy for inpatient falls. We started saying that we need to be working on this as an organization. We are an organization that has a 50-bed acute care hospital. We also have several clinics that are attached to our campus that are employed by our own doctors and patients. And so we started looking at it as a campus in general, you know, looking at the ER department, our outpatient departments, as well as our inpatient and our clinics. Some of the trends we were seeing is with our inpatients. A lot of our patients that fell had some cognitive issues. And with our outpatients, we were seeing more falls in our radiology department. And so we wanted to do some things to try to make our campus safer. Our department leader, also in the emergency department, we saw a trend where she felt like she was having more falls in the emergency room, but she really wasn't sure if she was or wasn't because we've never done statistics on it. So I'll kind of share that run chart with you later on in the slide. So if we want to go to the first one, we're going to talk about our emergency department first. As the fall team got together and we started looking at the emergency department and seeing what did they currently do for falls, when we took on this endeavor last spring, we found out that what they were doing was 30-minute rounding with their patients. But it wasn't focused really on safety and fall prevention. It was 30 minutes rounding to let them know how much longer it was going to be, what are we waiting on your test results, you know, I mean, it was to do everything with the patient, but they didn't really have a safety focus with it. Also, as we started doing some data, we kind of realized that it wasn't 100% across the board that they were giving the patient the call light, explaining to the patient and the family that we didn't want them up to the bathroom by themselves, that we wanted them to turn on their call light when they needed assistance. So we immediately, you know, had some issues. They were using no fall prevention tools, no communication tools, and they had no risk assessment for falls whatsoever. So we started researching what was out there, what have other hospitals done. We found a couple hospitals in Iowa. Mercy was one of them. I think Unity Point was the other one, that had already started this process and had developed a fall risk assessment for their emergency department. So we looked at a couple of their studies. One of the groups, I think it was Unity Point, was at the Iowa Falls last year for our national Iowa Falls program, and she was a speaker, so I got to spend some time with her. And it was very interesting. She shared all of her information, of course, with the talk, and so we felt like we weren't starting from scratch. So one of the things we did do is we developed our own fall risk assessment tool, and I'll show that in a couple slides and go over kind of what we ask. And we decided to do this at triage. Our nurses are triage at 0 to 15 minutes upon entry into the emergency department. So we decided we would try to get that fall risk done, as soon as we see them as a patient. We also gathered 3 years of data to measure our falls per month. What we did was we took our fall data that we had in the database and we divided it by how many ER visits there were for that month and then multiplied it by 1,000 so that we were, comparing our numbers correctly so we could see, how the numbers were looking. And it did really show that we have a run chart that I'll kind of go over with you that kind of shows it was kind of up and down, but that we did have an identified risk factor in the ER with falls. We did decide after doing the fall risk assessment that we would want them to use the same fall identification communication tools that we use on the inpatient side. We have staff that float from department to department, and we really didn't want to do something different than what we were already doing. So we have a yellow fall tab outside the door that you can pull out when you have a fall risk patient in the ER, which is just the same as what they have on the inpatient side. We will put a yellow band on the patient to identify them, and that's the same as what we have in the inpatient side. Some of our patients that come to the ER do not have appropriate footwear to ambulate, and if they don't have non-skid shoes, we will put our yellow non-skid booties on them. Otherwise, they can leave their shoes on. We identified that there were no gate belts in the emergency room, and we did have the department leader purchase gate belts for every room, and so there is a gate belt in every room, and we do kind of audit that and make sure that they're there and they've not wandered off. We also did some education with correct transportation, that we make sure as we take them from the emergency room to another department for testing that we developed a ticket to ride to complete our SBAR. One of the things we had noted was that the emergency room staff is very busy, and a lot of times when radiology would come over to get them for their testing, there was really nobody around to give a verbal SBAR. And you know how it is, everybody's got their own schedule and you got to get done, and so then the emergency or radiology staff would be taking them over possibly by wheelchair when we feel that they're safer to go over by bed. So we're going to talk about the ticket to ride in just a minute and how that, we have just started that, so I don't have a lot of data on how it's changing things yet. We also identified that patient and family needed to be educated on the call light and fall prevention tools so that they're part of the team and they know why we're using this. We're not trying to take away their independence, but we want them to be safe while they're here on our campus. We just recently remodeled the emergency room, so it was really nice. Our new stretchers have alarms on them because one of the things, we just had one portable alarm down the emergency room that we would use if we had somebody that was getting up on their own without assistance. So now we have a bed alarm on all of our emergency rooms on the emergency side, which is 4 of them, and then our other 5 rooms have a portable alarm that we can move from room to room when we need to use that. Next slide. This is our ticket to ride, and this is something that we just developed. We had recently we had a trend already that we had some falls in the emergency department, but some of those were like outpatient. These were like people in our ER that had gone over for portable chest x-rays that would have to stand, hold their breath, keep their balance. And we had 2 just recently that the doctor ordered a PA and lateral of the chest, and one of them was not considered a fall risk, but did lose his balance when he had to take a deep breath and hold it. It threw off his center of gravity. The other one was dizzy and weak and had a fall score when he went over. The nursing staff had told them that they needed to go by stretcher and he shouldn't be standing, but they had taken him over by wheelchair and stood him. And he ended up falling and actually getting laceration to his head that had to be repaired. So besides, some staff education and letting them know that, we need to be patient advocates, and if that patient's not safe to stand, that, you know, we need to talk to the doctor about ordering a portable chest x-ray, that the quality is really about the same anymore, and it would be safer for the patient, that we need to be advocates. But two, that we start developing a tool so that we have some good communication between departments to keep our patients safe. That we share that assessment that we have done with them so that they can, you know, keep them safe in their department. So Ticket to Ride is something new we just started, so I don't have a lot of feedback yet, but if anybody else has any, it'd be great to share with each other. This pretty much, we want to know their allergies because they get some medications over in radiology that could be affected. If they're a fall risk, yes or no, and can the patient stand alone, yes or no, and if it's no, they should not be getting them up. They need to be asking for a change of that order. The mode of transport, and if that's by bed, they need to not change it. That's how they have to go. Modality is something new. We're trying to educate everybody. We're also working on a new policy with safe patient handling, and part of that is using the same definition for their modality. So along with this tool is a definition of all those, so that we're trying to kind of train staff to talk in the same language so that we're all talking the same and on the same page with that. Excuse me. We also have on here if there's any special needs, any medications that can alter their mentation that would put them at risk for falls. We also thought we'd like to let them know if they're in isolation, yes or no, so they can make sure they protect themselves and everybody else in their department. There's a place to put in their oxygen, their IV fluids, if they have a chest tube or suction. We thought it was important that they know when they have their pain medication and sedation last, as that can affect their fall rate. And then the things we have to monitor. There's a place at the bottom for the primary nurse to sign and the transporter to sign as they bring them back. And there's a place, I think, for them to put a comment. So again, this is something new. It's a new tool we're trying to do to help with the assessment and hopefully keep our patients safer as they transport from department to department. We're just trying it in ER right now. Everybody else still is required to do their SBAR, and our Meditech system has a place where they can document their SBAR communication in the electronic health records. Next slide. This is an example of our emergency room fall tool. Again, it doesn't have as many questions as our inpatient one does, but it was focused mainly on our emergency room patients. And I know the scoring doesn't show up. Most everything's 1 point, except like the first one, history of fall, no, is 0 points. If they've had a single fall, it's 1 point. If it's a physiological fall with syncope, they get 2 points. And if they're prone to falls, it's automatically a 3, which automatically puts them at fall risk. Otherwise, it asks if they're confused or disoriented, intoxicated or sedated, and of course that's very specific to the emergency room because we do get a lot of patients that come in intoxicated or really sedated with too much medication. If they have impaired gait, if they need an assistive device, if they have altered elimination, polypharmacy, if they have 3 or more places they get their medications. And each one of those is worth a point. If they are 3 or above, we consider them a fall risk, and all of our fall prevention communication tools, and we're to use a gait belt with them while they're up for mobility. That way, I mean, in case they do have a fall, we can assist that fall and hopefully not injure our employees, as well as keep the patients from having any major injuries with a fall. And that they use the corrective assistive device to transport them by wheelchair. Currently, we do not have overhead lifts in our emergency department. All of our inpatient units have overhead Hoyer lifts. And so we are doing a capital, we're requesting that we have overhead lifts in the emergency room as well. They have the slide boards and they have wheelchairs, but they don't have the overhead lifts. And that's something we feel that they could really use. But anyway, this is our fall risk assessment tool, and we have started just this month doing an actual audit on a monthly basis over there. We're going to make sure that their fall risk assessment is being completed 100% of the time, and if they are a fall risk, they're using all their tools and they're keeping the patient safe. And this has come about because if you want to go ahead to the next slide, we really saw that once we instituted here in July, started really looking at their falls and instituting the risk assessment and the tools, you know, it was like a new thing and everybody was really thinking about it, was forefront on their mind. We were talking about it a lot. We really saw like 6 months in a row where it was just, you know, no falls whatsoever. And then we've had a couple and we kind of think part of it's, you know, we got to hardwire all those tools and get that culture of safety in the emergency room, you know, that they started really pretty good, but yet then once we kind of backed off, I think they got a little lax too. So we're going to kind of start auditing it and making sure that they know it's important and we get that culture of safety in there. I know this last month that I coached a couple of the nurses, and one of them like wasn't completing the fall risk assessment in its entirety, you know, and another one was, you know, a little hit and miss, so it was just kind of coaching about the importance of that and what they do with that information. They were all able to tell me what preventative tools they would use and what they do, and it sounds like they're really great about doing it, and when I'm up there, I see it done. But it's just kind of making sure we keep building our culture of safety in that department. So that's kind of what we've done for the ER. And again, I am actually tracking and trending these numbers on a monthly basis. And then the run chart gets printed as well with the inpatient one and gets posted in all the departments. And they talk about it at their department meetings on a monthly basis. So we're trying to share that information back with the staff so they know what a great job they're doing and they can see how those numbers change over time. All right, next slide. So then on the inpatient side, we were still working on our policy. We were like updating our policy. And we've done some different things with the inpatient side. One, we had some issues with our chair alarms, and one second, I'm getting ahead of myself. So anyway, on the inpatient side, our fall risk assessment, we looked at that as a group. It wasn't really referenced, so we felt we were able to adjust it and change it. So one of the things we wanted to do is we saw that a lot of our cognitive patients were having falls, and so we wanted that to be, if they had a cognitive issue, to just automatically be a fall risk. And so we changed these three numbers. If they were unsteady on their feet or they had syncopal episodes, they were automatically a fall risk. We gave them an 8. They got an 8 for that, so they just were automatically a fall risk. If they had a recent history of falls within the last 6 months, they were automatically a fall risk. If they were confused or disoriented, they were automatically a fall risk. And then we kind of looked at the tool to make sure it worked okay with, say, we got somebody that was in their mid-50s and they just had a recent knee replacement and they have an IV and they have some altered elimination, you know, would they be a fall risk? And I mean, we kind of did it to make sure that our numbers all worked for our assessment. So it looked like our fall risk assessment, we all liked it as a group. It seemed like it was working great. We put it into practice. It's really done a better job for our nursing staff. The policy initially had, if they were a fall risk of 5 to 7, they would use like the communication tools and certain tools, but not all of them. And then if they were a fall risk of 8 or greater, then they would use the alarms and all the tools, and we thought that was too confusing. You know what? We feel everybody that comes to our organization is at risk for falls, and we need to protect everybody. But once you're a fall risk, we feel like you're just a fall risk. There isn't like a low, medium, high. We just feel like you are. And so we changed the policy to make it simpler that pretty much once you're a fall risk, you're a fall risk, period. You use all the tools and put them in place. So with our assessment, it is required that they get a fall risk assessment on admission. Every shift has to reassess that fall risk. If we change their medication from a doctor's order and it's medication that can, you know, sedate them or change their mentation, they have to do another fall risk assessment. And if they've had a fall, they need to reassess that and document it. Our fall prevention tools is probably very similar to what most people use. We identify their fall risk outside the door, and we have a yellow tab we can pull out. Our special care unit and our OB department have yellow stickers they put on the doors. They have a yellow band we put on them. They wear yellow booties as opposed to blue booties so that we know they're a fall risk. We, again, identified the really teaching to use that gate belt all the time. If they're a fall risk, that gate belt should be on every time we have them up. It's not, the policy's written, it's not a decision that they can or can't. They have to have it on as a staff member. So any transfer, any mobility with a fall risk patient, they have to have their gate belt on. We have bed alarms on every bed, and those are to be used. We did a nice little, we've gotten some new striker beds, and I had some of the aides with me one day, and we were like, you know, testing the new alarm, and I was in bed, and I was showing them all the different positions, and we kind of identified that the exit alarm that they normally put it on really doesn't go off until I could stand up and probably walk about a good 4 or 5 feet, and then it would go off. And so that really opened their eyes, and of course we did some education and sent out an email and trained everybody that we really needed on that middle mode. So now, and I've checked it, it's always, everybody's doing a great job, but we have it on that middle mode. We were finding out there was just too big of a delay in that bed alarm, that you really need to test your modes with somebody in that bed and see how long it takes for that to truly alarm. And if there's that big of a delay on it, you know, you might want to change your mode. And we did that. We changed our mode to the middle mode so that we don't have that delay of getting into that room to help that patient. Our chair alarms are just one patient use, sensor pads. We did find chair alarms that have an alarm in the room as well as an alarm we can put outside the door that responds by audio. You can hear it going off, but it's also visual. The light on the below it goes off. And that helps if you have like 3 or 4 chair alarms in the same area. You can also look at the alarm and whichever one's lighting up, you know, to go into that room. The thing with the chair alarms is they don't go into our Hill-ROM system, so you can only respond if you're in the area. So we, again, orient and train everybody that way. We also have a no-pass zone that we train all new employees and every department that if they are up on the floor and there's an alarm that they respond to it. We don't expect them to do clinical stuff or mobility assistance, but we expect them to do their Audit, go in the room. They know all the communication tools of how to get assistance. There's a staff emergency button, and they learn where the call lights are and how to get assistance to the room. And we ask them to keep the patient as safe as they possibly can with their skills, talk to them, distract them, buy our staff some time. So we do that with the inpatient side. Next slide. So one part of the assessment in the policy that we changed is we did consider any patient in our organization to be at risk for falls. So the policy does state that, and this, I just kind of took this from our policy. And so we expect everybody to have their call light within reach before we leave them, to have a bed or chair in the low and locked position at all time, to be sure we're orienting everybody to the environment, because this is different than being at home. And during orientation, we talk to everybody about, you know, it's nighttime, and I know you're trying to keep the lights dim, and you're not trying to wake everybody up, but when you get them up to the bathroom, you need lights on. You need to be well lit. You need to make sure they know where they're at, they see where they're walking. You don't want to be walking them in the dark. The appropriate footwear, and we have the non-skid booties, but what's so funny is I had a fall in the past where the supervisor got a patient up at night and put on her house slippers, which were slick, and had her in our tiled bathroom, and then when she got up from the toilet, that slid and she fell. And so it's just that educating everybody that, you know, even if you're not a fall risk, you've got to think about those things, and you don't want slick footwear on. That we keep their personal items within reach. We don't want them reaching or trying to get up without assistance. 2 top rails up at the bed at all times. Educate our patient and family about why we're doing these fall protection things, and make sure that they understand that we're not trying to take away their independence. We want to keep them safe. It's a different environment, and they have sometimes IVs and tubes and stuff in, and you're in bed more often, you're just, you know, don't have as good of a steady gait, you get lightheaded and dizzy, you're just weaker. So we did also institute a call, don't fall policy, In all of our rooms, we added a bright yellow magnet that says call, don't fall, and so we encourage everybody to please turn on their call light when they need to get up. We would like to be there for standby assistance just to be sure if they need anything, we're there. Make sure we clear our pathways. We talked about lighting, that we have the correct assistive devices, and that if we don't know how to measure, we have physical therapy come over and make sure their walker that they brought in is appropriate for them. And then, of course, we can also have therapy come over and do an assessment on them. All right, next slide. So as we have been teaching our staff to do the correct fall assessment, another thing we think is important with assessment is the communication. So we do a monthly safety audit. We started doing this over a year ago, and we did it twice a month, and now we're down to monthly. We're not 100% across the board, but we're awful close. You know, we're just like one patient, you know, blows it for us, one or two. But we actually go up on the floor and go to every patient's room. And I know this didn't print very well, and I'm sorry for that, but we look to make sure, well, the first one's med drawers are locked and pull cords, but that's kind of some other, you know, you're up there, so you're doing other issues. But we do make sure we look at their bands, that all the communication or bands are on and appropriate for that patient. We have some VTE stuff on here, too, because I do it with quality. But we do a safety check, and we make sure all the safety things that patient should have are in place and on. That their whiteboard is completed. That's our communication board, so we think it's important that we have the right communication, that their fall risk score from the chart to the Cardex to the whiteboard all match, all have the same number. We're checking their Cardexes for communication as well as their chart. So we're doing a lot while we're up there. It kind of started as I wanted to be checking on our safety tools with falls, but we've kind of added VTE stuff and the whiteboard communication and some other things. But it's been really great because I go up there and they see me and they're just like, oh my gosh, I need to make sure my whiteboards are updated. You know, as soon as they see me, it just makes them think about that. So that's been going well. Next slide. Another thing that we have been doing is all of our falls are reported in Quantros, which is a variance reporting software for us. So as we talk about assessing for those falls, it's really important that everybody knows that once we have a fall, and I am talking inpatient fall, ER fall, outpatient fall, clinic fall, grounds fall, all of our falls get recorded. And we track and trend all of them. We want to see if we have more, you know, outpatient falls, are we having any in a certain department, what can we do to keep it safer for everybody. So one thing is we do document it in our safety event in Quantros. There is a post-fall assessment in Quantros that they have to fill out that asks a lot of really pertinent questions of if they've been assessed for a fall lately, has physical therapy worked with them, were they on any medications that made them prone to falls. But then we also felt that there wasn't all the questions we had, so we also developed a post-fall huddle form, if you go to the next slide. So this is our post-fall huddle form, and what it is asking the questions our safety online system doesn't ask. So it's not all-inclusive because the other questions are already in our safety event reporting where we do a post-fall assessment and a post-fall huddle. So we require a post-fall assessment by the staff nurse, any of the aides that were, anybody on the department that's involved with this patient's care, and our supervisor. If we have somebody fall, once we have taken care of them and put them back in a safe place and know they're doing okay, then we do a post-fall assessment. And then we do a post-fall huddle. And we want these people to get together and, you know, did we have a piece of equipment not working? Did we not use our equipment correctly? You know, does this person need one-on-one sitter? Or do we have a cognitive issue? They need to get together and brainstorm, and what do we need to do to keep this person safe going forward, and they need to institute that. But then they also have to complete this post-fall huddle form, and then that comes down to me to track and trend, and I share that with the department leader as well as it's in our safety event. I put it in our computer system so that we can track it. And so besides making sure they have the correct fall tools on and the other questions, we kind of wanted to know excuse me, the number of patients we had during that time and what our staffing was like, and how many fall risk patients we had, and how many people were actually on the unit at that time, and how much time had actually elapsed since they last rounded on that patient, last time that patient went to the bathroom, and if they're continent or incontinent or have a catheter. And was fall risk communicated to the staff in shift report? We want to know if they're talking about it at shift report. They're supposed to be talking about it at shift report in their huddles, and the supervisor is supposed to get it during their report. Was our patient compliant with our fall prevention plan? And was there a mental status change from baseline since the fall? And were there any psychological changes prior to the fall? And then, of course, any comments, we want them to write in anything they can think of that they think is the root cause or the contributing factor to the falls. Again, you know, everybody's trying to track and trend and see, you know, what we can do, what's out there, what, you know, how can we keep our patients safer. Next slide, please. This is our inpatient fall run chart that it starts from October 2014. Our institutional goal is to be less than 2.77. The national one I can find for med-surg department was 3.92. So that's the two lines. The green line's our goal line, the other ones are the median line. And we're doing better about getting down below that. And I would have to say with our trending, most of our falls that have happened have been people, again, with a cognitive issue. I can specifically remember one that was in with Alzheimer's dementia. We had one-on-one with him. I mean, he came to our meetings and everything, but he's just up and never sat still for 2 seconds, up, down, moving around, all over the place. But at this time, he got agitated and was like batting at the employee to get away from him and lost balance and fell, and so that was, you know, what caused his fall. And again, you know, we're always trying to get our numbers, and it'd be great to say we're never going to have a fall, but we all know what the acuity is on the inpatient side and the type of patients we get, and that's probably never going to happen, but we want to do the best we can to keep them safe and keep our employees safe. Next slide. I know I kind of already talked about that we do a no-pass zone. This is the YouTube video that we kind of share in orientation, and then we have a quality handout that we pass out. I think the next slide kind of shows you our handout for like no pass zone. And so we orient all of our new staff that, you know, as they're here, that we expect everybody to keep our patients safe, both inpatient and outpatient. Outpatient, we talk about that 10-5 rule, and as we talk about, you know, the 10-5 rule and making sure we assist them to go anywhere they need to go, I remind them that we need to assist them to go there safely. So if somebody needs some assistance, they're coming from the clinic to radiology, and they don't look very steady, or they're asking directions and we walk them there, we may also need to get a wheelchair to take them there. That we want to make sure we safely get them from place to place as we're escorting them. But we definitely go up to the inpatient side, and I show them all the communication tools we have, and it doesn't matter if they work in dietary department, in the business center, in accounting, in the clinics, they all get the same orientation, and they all know the communication tools on the inpatient side, how to respond to an alarm, what their expectations are. Because we do think it takes all of us to keep our patients safe. Next slide. So our fall team is a multidisciplinary team that meets monthly, and so we have somebody from, you know, several different departments, even somebody from dietary sits on the fall team. And like I said earlier, we wanted to make a hospital-wide fall assessment. Some things that we did is we definitely had the departments purchase gait belts, and once we started looking, I mean, we've already talked about the emergency room not having gait belts, but ambulatory surgery just swore they had a gait belt. They couldn't find one for us anywhere, so we added a couple gait belts in ambulatory surgery. OB department that does epidurals and then gets them up for the first time walking when sometimes they don't have good filling in their legs, or, you know, I mean, they tested them and they should, but maybe they're not very steady. They've got gait belts now. Our radiology department was a department that really needed gait belts. We had a lot of falls in, and of course we We did gait belts with them. Therapy came over and taught them how to use them, and they thought that's really helped a lot. I mean, one time they had, you know, a lady walking down to get her CT scan, which is quite a walk actually, but it's all the way through their whole department. And she had a cane, and they were walking with her, but she ended up falling, hitting her head. She had to go to the ER and get assessed by the ER doctor, had to have a head CT, had to call her primary doctor, then eventually got her testing done once everything was cleared. And of course, at that time, she's like, oh, I've been falling a lot lately. This was before we started doing our outpatient fall risk assessment. And so now we do an outpatient fall risk assessment, which we'll talk about next. We already talked about no-pass training and doing that at orientation. We have wheelchairs pretty much by all of our entrances now so that they're hopefully readily available for people. And we assist our, you know, employees. It will assist anybody to get from department to department. And I already talked about that we added the call, don't fall signs in all the rooms so that people, you know, sometimes you just have to give them the permission that we want you to turn on your call light. We're here to help you. You know, a lot of patients, they don't want to bother us. They don't want to turn on their call lights. They want to be independent. They think they'll be okay. And you really need to, you know, give them that permission that this is what we want you to do. We want you to turn on your call light. We want to come in here and be here while you're getting up and around to make sure you're safe. That's what we would like you to do. And so, you know, you just need to let them know that that's the culture we have and it's okay. We're also doing safe patient handling monthly checks through the HIN organization. So we've been going to all of our departments that do any patient mobility and do safe patient handling checklists. And that, honestly, I'm sure we're all doing that, but that's an eye-opener. You know, we've identified some areas for improvement, and I think that's a great assessment tool that they have. And then we have a subcommittee that's meeting, and we are working on our safe patient handling policy throughout the whole institution as well. So if anybody has anything on that, I'd love to share because we're just kind of starting working on that. So next slide is our outpatient fall prevention assessment. So this is what we decided. We looked for some tools that were out there, and we decided we wanted to keep it brief and short. We felt like a lot of the outpatient registrars ask a lot of information already. It's a lengthy process. We don't want to make it too long. But we decided if we ask these three questions: are you lightheaded or dizzy? Have you had a recent fall? And we specifically did not put a time factor on that on purpose. And do you need help standing or walking? If they answer yes to any of those three, it flags them as a fall risk. When that order goes over, it shows that they answered yes to those, and it puts them as a fall risk. And what that does is it allows that staff member who's coming to get them to know that they're a fall risk. Because in the past, radiology would just come out and like call your name, expect you to come walk to them. But this way they know they're a fall risk, and they know, one, if I'm taking them down to the CT or MRI room, which is quite a walk, and it says they're a fall risk, I am to take a wheelchair out with me and try to encourage them just to go in the wheelchair. And if not, and we know what people are like. I mean, you might be a fall risk and you don't want to say you are. But if I don't come out with a wheelchair and say, well, it's a pretty long walk, do you think I need to get a wheelchair? They're going to be like, no, don't go do that. But if you already have it there, they're more apt to, you know, agree with you and use that. But then we also have the gait belts that they can use, and then they also know that they're to make sure that they're assisting them and not, you know, walking with them and to keep them safe. So this has really helped. I think the departments feel like we have more of a culture of safety, that we're really focusing on people and trying to keep them safe. If we have somebody that falls on our grounds, and of course we know about it, we immediately go assist them. Any first aid, encourage them to be seen in the ER by their doctor. We get a wheelchair, we assist them. We actually call Dr. Rapids on people that fall out in the grounds and we need assistance, so that we get a quick response and we take care of them. And then I follow up and call them in 24 hours and make sure they're still doing okay and they don't have any injuries. But anyway, I think that is the majority of our assessment and where we are. Again, this is an ongoing process. There's always new things that we're learning from each other and working on. And so I hope this added some things you guys can think about. Any questions, but there's nobody there.
Thanks so much, Barb. There isn't anyone on this as this is recording, but I know that this information has stirred a lot of thought among our community of practice members, especially related to some of your outpatient assessments. So for those of us that are listening to this recording, Barb has been kind enough to share some of these resources that she's overviewed with the community of practice, including a copy of their Ticket to Ride assessment, the post-fall Huddle form, and a safety audit form. So those resources were shared through email to all of the registrants and will also be posted to the website and through the HIN Hub. So of course, you may also reach out to Jennifer Kriegmer or Jennifer Brockman for additional access to those resources, and I'm sure that Barb would be happy for any connection as well if anybody would like to follow up.
Oh yes, I probably should have had a slide with my name and contact number. I didn't even think about it.
Not a problem. We can share that out with some of the resources. So the one thing I would like to highlight, in addition to these tools that we've overviewed, IHC, as part of our HIN participation, there is an active toolkit that we have available. So you're able to see that by going to the IHC website. So I'm going to kind of pull that over right now. The really cool thing about this is that not only can you print it out, but you can also have it in PDF form. So as you can see, it's quite a full toolkit that's here. But you can always look for Find, type in falls, and it's going to connect you with exactly where you can find falls and immobility resources that align with our focus areas throughout the hospital engagement network. As I mentioned earlier, we will also be posting some of these resources through the HIN Hub. For those of you that are already part of the HIN Hub, that is excellent. We're glad to have you on there. For those of you that haven't yet, the HIN Hub is a resource sharing platform for us where you're able to connect directly to your IHC staff as well as to other hospitals. You can post questions, you can follow topic lines. It follows a social media type of platform, and it's really easy to use. So if you go to a Health Doers website, I'm just going to kind of give a quick overview for what the HIN Hub looks like. But you'll use your email address. You can type in your password, and as you can see, it's really easy if you have the right password here. All right, well, it's not letting me in here for that one, but when you get in there, the one cool thing that it has is that we do 2-week topic cycles for all of our topic areas in through the HIN, including falls, and it's also a great area if you have questions that you'd like to ask to Barb or to the greater HIN network. It allows us to all see that and filter in for that. So if you are not part of that, please reach out to Jennifer Kriegmer or Jennifer Brockman, and they will get you the link for that. So just a couple reminders for some great tools that we have access to as part of our HIN participation. Last notes that I would like to add is that we do have a couple of upcoming education events. So save the date. We know that the HIN regional meetings are ongoing right now. So tomorrow it's in Storm Lake, Waterloo on the 25th. Waterloo on the 24th, and Atlantic on the 25th, and then back in Des Moines on the 26th. So that is this week. I know many of our community of practice members were intending to be there. So if you weren't able to be there on site, reach out, and we're happy to share some of those materials with you, again, focusing on quality improvement and run charts and how we can use our data to better improve the success. And as you can see, Barb and Fort Madison have really used access to their data to, number one, target where their problems may actually lie, such as in the emergency room, and then moving that forward and seeing how the interventions that they've been putting into place have impacted their falls. So in addition to our regional meetings, the next HIN learning community is June 14th. This will be an in-person event here in Altoona, and that's at the Meadows Events and Conference Center where we typically hold it. One really great thing is that we are able to offer a $175 travel stipend for all of our critical access hospitals, so please reach out early so we can make sure to get you in there for that. There will also be a care coordination conference the next day on June 15th. So if you are making the trip down, you can kind of tie those two things in together and get 2 days worth for your bang for your buck. As a HIN learning community is free registration on there. There's also a Falls Coalition Symposium that will be held on July 8th. There is a $35 registration fee, but there are some really great speakers and content that will be featured as part of that event. And then our last event we just want to make sure everybody has on their radar is the IHC Annual Conference, which will be held on August 16th. That event will be very robust. We'll have some national keynote and plenary speakers, and then we'll have 4 breakout tracks that we'll be offering, looking at kind of a leadership track, overviewing some of the great initiatives that we have going on throughout the state, not only the Hospital Engagement Network, but the Transforming Clinical Practice Initiative and the State Innovation Model that a lot of our hospitals are wanting more information on and knowing where they fit in that and how we can use those resources to further advance the care we're providing in Iowa. There'll be a track for population health and patient and family engagement, as well as a track specifically for care transitions, and then also one focusing on performance improvement and really driving in content that has been found to be pertinent to you guys as the HIN hospitals for that. So it'll be a great event. I'm sure you won't want to miss it. So. The only other reminder that I have is that all of these community of practice webinars are recorded, so you're able to access those through the update link that is on the IHC webpage that you'll see here. Just simply go to News and Events and you'll be able to see the different archived drumbeat issues and the postings that will be happening in through this arena. You're also able to reach out to Jennifer Creekmer and Jennifer Brockman if you'd like to receive any additional information, or if you're not able to find it on the website. We are here to help, so we are very happy to do so. So that is all that we have for you today. Again, I'd like to thank Barb for joining us and sharing Fort Madison's story, and along with all of the great resources that she has. Again, this really exemplifies what we're trying to do as a community of practice, of coming together, building off the experiences that we've had to help, improve the care for Iowans and to make sure that we avoid as many falls as possible. So thank you very much, Barb, and thank you to everyone for joining the community of practice today.
All right. Thanks, Katie.